Welcome to the deep dive. Today, we're diving into a set of revision notes, really getting under the skin of panic disorder.
Sounds good. It's a topic that comes up a lot.
Exactly. And think of these notes as our map for today. We're going to navigate through them together, pull out the really crucial bits, the high yield points you need to grasp this quickly.
Yeah, right to the core information.
That's the plan. Turn these detailed notes into a clear, memorable, deep dive. We'll cover everything laid out here. The definition, causes, risks, what's happening physiologically, how it looks, how you diagnose it, management, prognosis, and potential complications.
The comprehensive look, then.
Absolutely. Okay, let's unpack this. Let's start right at the beginning. How do these notes actually define panic disorder? What exactly is it?
Okay, so at its heart, the source material defines it by having recurrent, unexpected panic attacks. That word unexpected is pretty key, especially initially.
Unexpected meaning. They just happen, out of the blue.
Pretty much, yeah. And we're not just talking about feeling a bit anxious. The notes describe these attacks as like intense bursts of fear or massive discomfort that peak really fast, usually within minutes, and they come with a whole load of physical and mental symptoms.
Right, so it's the intense fear plus physical stuff happening.
Absolutely.
Mm-hmm.
The notes list things like heart palpitations, sweating, shaking, feeling like you can't breathe, chest pain, stuff that feels really scary, like you might be having a heart attack or something.
Wow, yeah.
But the definition of the notes goes further. It's not just having the attacks. A really key diagnostic point is that after having these repeated attacks, the person starts persistently worrying about having more attacks, or they change their behavior in significant ways to try and avoid them.
Ah, okay. So it's the attacks and then the ongoing worry and avoidance. That's what makes it the disorder.
Exactly. That leads to what the notes call anticipatory anxiety, that sort of constant dread about the next attack and those avoidance behaviors. And they can really shrink someone's world.
Yeah, I can see that.
The source also gives a quick mention that treatments often involve things like CBT talking therapy and certain medications like SSRIs. But we'll get into the management details later on.
Okay, good. And do the notes give us any stats up front? How common is this, according to the source?
Yeah, this first section puts the prevalence at around 1.5 to 2.5% in the general population. And it notes it's diagnosed more often in females.
Okay.
It also points out two kind of interesting age peaks for when it typically kicks off. One in younger adults, say 15 to 24, and then, maybe surprisingly, another peak later on, between 45 and 54.
Right, so that's the what. Now the why. This is where it gets really interesting, I think. What do the notes say causes panic disorder? Is it just one thing?
No, the source is clear, it's complex. Definitely not just one single cause. It's presented as a mix of things: genetic vulnerability, biological factors, and what's happened in someone's environment.
So like, does it run in families?
Very much so. The notes really emphasize a strong genetic link. If you have a family history, your risk is significantly higher. And biologically, it seems to involve, well, dysregulation in key brain circuits and chemicals neurotransmitters, especially serotonin and norepinephrine, which affect mood, stress, and fear.
And what about life experiences? Stress?
Yes, stressful life events are definitely flagged as major risk factors. Things like trauma, big losses, major life changes, they can often act as triggers for the onset.
Okay.
And interestingly, the notes also mention connections to certain substances. That includes some prescribed meds like SSRIs sometimes, or perhaps more commonly, withdrawal from benzodiazepines, which can actually provoke panic symptoms.
Huh. That's interesting about the SSRIs. And the notes list some other risk factors too, don't they? Sort of more specific circumstances?
They do, yeah. This section specifically adds things like living alone, losing a parent early in life, having a history of abuse, physical or sexual, lower educational level, and even living in a city, an urban environment, as factors that can increase risk.
Okay. And building on that, there's a whole separate section just labeled risk factors. Does that add much more, or is it mainly repeating those points?
There's definitely some overlap, as you'd imagine, but it helps solidify the main ones and maybe adds a slightly different emphasis. Family history gets another strong mention, so does that history of physical or sexual abuse.
Right.
Major life stressors pop up again, but this section maybe highlights substance abuse a bit more directly as a risk factor compared to the etiology section.
And wasn't there something about personality type?
Yes, that's a key addition here. The notes mention having high neuroticism or being particularly sensitive to stress. Basically, a tendency to experience negative emotions more intensely or react more strongly to stressors.
Okay, let's get a bit more technical for a sec. Pathophysiology, how it all works, biologically. What's the explanation in the source?
Right, so under the hood, the source talks about problems with the brain's fear circuitry. It points to areas like the amygdala that's crucial for fear processing, the hippocampus for memory context, and the prefrontal cortex, which helps regulate responses. These areas are described as being, well, dysregulated.
Like the brain's alarm system is a bit overactive or faulty.
That's a good way to put it, yeah. The notes bring up those neurotransmitter issues against serotonin, norepinephrine, and also GABA, which usually helps calm things down. Imbalances here contribute to this whole system being hypersensitive.
Okay.
So the core idea is that the stress response system is basically firing off these exaggerated false alarms, leading to those really intense, often unexpected panic attacks. It helps explain why the body reacts so severely, sometimes even when there's no obvious trigger.
Okay. Now, zooming out to the bigger picture epidemiology, what's the UK perspective according to these notes? How many people are affected?
So this section gives a slightly different figure than the definition section did. It states panic disorder affects about 2 to 3% of the UK population.
Ah, okay. So the notes themselves have slightly different numbers there. Worth noting.
Exactly. It's good to be aware that source materials can sometimes have those minor variations. This section also repeats that it's more common in women and usually starts in late adolescence or early adulthood. That lines up with the first age peak mentioned earlier, though it doesn't mention the later one. Again, just relaying what the notes say.
Right. So how does someone actually present clinically? If someone comes in, what signs or symptoms are highlighted in these notes?
Well, the clinical presentation section really hammers home that recurrent, unexpected panic attacks are the absolute hallmark. And the notes give a pretty detailed list of the symptoms someone might experience during an attack. These are really crucial for recognition.
Yeah, let's run through those. They really paint a picture.
Okay, so the list includes palpitations or your heart pounding, sweating, trembling or shaking, feeling short of breath or like you're smothering, a choking sensation, chest pain or discomfort, nausea or stomach issues, feeling dizzy, unsteady, lightheaded, or faint.
That's already a lot.
And there's more. Feelings of unreality, that's derealization or feeling detached from yourself, depersonalization, a fear of losing control or going crazy, a fear of dying, which is common, numbness or tingling like pins and needles, and chills or hot flashes.
Wow. That is a really intense constellation of symptoms, both physical and psychological.
It really underscores why the attacks are so terrifying for people. The notes stress that the diagnosis really hinges on taking a good, detailed history from the patient. Their story is key.
Right.
Attacks shoot up really suddenly, and like we said, they can be unexpected or sometimes triggered. But those unexpected ones are vital for the panic disorder diagnosis itself. And crucially, the notes point out there aren't usually any specific physical signs to find when you examine someone between attacks, only during one, potentially.
And what about other conditions? I feel like panic disorder often doesn't travel alone.
That's very true. The notes highlight significant comorbidity, other conditions happening at the same time. Agoraphobia is a big one, often developing because people start avoiding places where they fear having an attack and not being able to escape easily.
Makes sense.
Social phobia can also co-occur. And a really critical point mentioned here and again later is the high association with depression and a significantly increased risk of suicide. That's vital to remember. Substance misuse can also complicate the picture.
And any physical conditions to be aware of, things that might look similar.
Yeah, the notes remind us that other physical health problems need to be ruled out as the cause of the symptoms. But they do mention associations, not necessarily causation, but associations with things like cardiovascular issues, migraines, and IBS, which can sometimes share some overlapping symptoms like palpitations or nausea.
Okay, that leads nicely into investigations. Given all those physical symptoms, you'd think there'd be a bunch of tests needed. What do the notes actually say about investigating panic disorder?
This is a really key point from the notes and definitely one to remember for revision. There are no specific laboratory tests that diagnose panic disorder itself.
Really? So you can't just, I don't know, do a blood test or a scan to confirm it?
Nope, not for the actual diagnosis. The notes state pretty clearly that the diagnosis is based primarily on that thorough clinical assessment, the history, and evaluating the pattern of symptoms and behaviors.
So when are tests used then?
Investigations are mainly done to exclude other underlying medical conditions that could be mimicking the panic symptoms.
Like what sort of things?
Well, the notes suggest that if the history or exam makes you suspect something else, an organic cause, you might consider blood tests, maybe thyroid function tests or checking blood glucose. A toxicology screen could be useful if you suspect substance use or withdrawal is playing a role.
Okay.
And while psychological assessments or rating scales can be helpful, maybe for tracking severity or treatment response, the source stresses that the core diagnosis remains clinical, based on the story.
All right, let's talk treatment, management. How do the notes suggest helping someone with panic disorder?
The notes really emphasize a combination approach as being most effective. Usually that means psychotherapy working alongside medication.
Okay, what's the go-to therapy?
First-line psychotherapy mentioned is cognitive behavioral therapy, CBT. Specifically, panic-focused CBT, which directly targets the thoughts and behaviors that fuel the panic cycle.
And medication-wise?
SSRIs, selective serotonin reuptake inhibitors, and SNRIs, the serotonin norepinephrine ones, are highlighted as the first-line medication choices. The main goal there is to reduce how often the attacks happen and how severe they are, and also ease that anticipatory anxiety.
Makes sense. Are there other things that help?
Yes, the notes also mention things like relaxation techniques, general stress management skills, and the value of support groups. These can all be really useful additions. The source also introduces the idea of a stepped care approach, a framework often used in the UK, where you start with less intensive treatments and step up if needed.
Right, the stepped care model. Let's break down what the notes say about the non-drug approaches first. Non-prescribing management.
Okay, so education is highlighted as crucial, helping the person understand that panic attacks feel awful but aren't actually dangerous physically. That's a big step. Reassurance is also vital.
Right.
And the notes say the aim should be managing symptoms effectively, not necessarily aiming for zero anxiety ever again, which isn't realistic. Monitoring the attacks, frequency, severity, triggers is important too.
And how do you decide where to start treatment?
The notes suggest the first-line choice could be medication or a structured self-help program based on CBT principles or face-to-face CBT. It depends on things like severity, patient preference, and what's available. It mentions that CBT involves changing thoughts and behaviors, often using exposure techniques, and that CBT-based self-help can also be effective.
Okay. Now, what about the prescribing side? You mentioned SSRIs, but what about faster-acting things like benzodiazepines?
Yeah, the notes address those. Benzodiazepines, like diazepam, can be used for very short-term relief in an acute crisis, maybe while waiting for an SSRI to start working properly. But, and this is important, they are specifically not recommended as the main long-term treatment on their own, mainly because of the risks of dependence and tolerance.
Gotcha. So SNRIs are the mainstays.
Yes, they're the first-line drug treatment. And the notes suggest that once someone responds well, the medication should often be continued for at least 12 months after they're feeling better to help prevent relapse.
And if those don't work?
If someone tries, say, 2 different SSRIs or an SSRI and an SNRI for a decent amount of time, like 12 weeks, with dose adjustments and they're still not getting enough benefit, then the notes suggest considering tricyclic antidepressants, TCAs, as a second-line option.
Okay. And monitoring is key, I assume.
Absolutely. Monitoring for side effects, checking how well the treatment is working. The notes even suggest using things like self-completed questionnaires to track progress objectively.
Yeah.
And when it comes time to stop an SSRI, it needs to be tapered off gradually, ideally in discussion with the patient.
You mentioned the nice stepped care approach earlier. Can you quickly outline the steps listed in the notes?
Sure, the source lists these 4 main steps.
Recognition and diagnosis. Just identifying the problem.
Treatment in primary care. Offering low-intensity options first, like guided self-help.
Review and alternative treatment. If step 2 isn't enough, consider referral for higher intensity CBT or starting antidepressants, especially for moderate to severe cases.
Review and referral from primary care. If someone hasn't responded well to 2 different interventions tried in primary care, they should be considered for referral to specialist mental health services.
So it sounds like the overall UK approach described here is pretty structured and multifaceted.
Yeah, it's summarized as that combination of therapy and medication, guided by the stepped care model, with a strong emphasis on education and self-help right from the start.
So what's the outlook then? If someone gets this diagnosis and gets treatment, what does the prognosis section say?
Well, the good news, generally speaking, is that the prognosis with appropriate treatment is described as positive in the notes.
Oh, that's really encouraging.
It is. Many people see a significant drop in their panic attacks and a real improvement in their day-to-day functioning and quality of life. The notes really stress that getting help early and sticking with the management plan are key to achieving that.
But it's maybe not always a complete cure, or it can come back.
That's right. The notes do point out that some individuals might still have some lingering or residual symptoms even after treatment, and relapse is possible, especially during stressful periods later on. And unfortunately, that critical point about the increased risk of attempted suicide is reiterated in this prognosis section too. It's a serious aspect of the disorder. The advice given is that even if someone feels recovered, they should know to seek help again quickly if symptoms start returning.
Okay, and finally, the flip side, complications. What happens if panic disorder isn't managed well? What potential problems are listed in the source?
If it's untreated or not treated effectively, the notes list several potentially serious complications. One is the development of other anxiety disorders, and agoraphobia gets another specific mention here as something that can develop out of panic disorder.
Right, and effects on mood and behavior.
Definitely. There's a high risk of developing depression or making existing depression worse. The notes also repeat the increased risk of substance abuse we saw that mentioned earlier, trying to self-medicate the anxiety perhaps. And again, that higher likelihood of suicidal thoughts or behaviors is listed as a major complication.
And just in terms of daily life.
It can cause significant problems with functioning socially, at work or school, just making life much harder. This can also lead to people using healthcare services more often because the physical symptoms are frightening and need checking out. So the notes really circle back to emphasize that getting timely, effective help is absolutely essential to try and prevent or at least lessen these complications and just improve someone's overall well-being.
Right, we've really walked through these notes now, haven't we? Covered the ground from the basic definition right through to potential complications of panic disorder. We've tried to pull out that core information, break it down section by section, kind of like you would if you were revising or trying to get your head around it quickly.
Yeah, hopefully seeing how it all links together, the biology, the risk factors, how it looks clinically, how it's diagnosed and managed, gives you a much clearer picture of the condition. Solid foundation.
You know, thinking about everything we've discussed, those really intense physical symptoms, the fear of dying or losing control, and that undeniable link to depression and even suicide risk. It really makes you think, doesn't it? What does this condition tell us about just how deeply connected our minds and bodies really are? Okay, that wraps up our deep dive into these panic disorder revision notes. We've aimed to extract that high-yield info to give you a solid, quick understanding.
Absolutely. Nailing down these key points, from what defines an attack to the treatment options and likely outcomes, is really crucial whether you're facing exams or just want to understand the condition better.
Yeah, and if you are using this for MSRA revision or something similar, keep coming back to these core areas we've talked through. For more resources, practice questions, that kind of thing, you can find help over at passthemsra.com and also at freemsra.com.
Definitely worth checking those out. Thanks for joining us for this deep dive today.